Aripiprazole therapy in schizophrenia and dopamine partial agonism. Schizophrenia affects approximately 0.3% of the global population, with a lifetime prevalence of 7.2 per 1,000 individuals. The disorder is characterized by dysregulation of dopaminergic neurotransmission, particularly hyperactivity in mesolimbic D2 receptors and hypoactivity in mesocortical pathways. Diagnosis relies on DSM-5-TR criteria requiring greater than or equal to 2 symptoms, e.g., delusions, hallucinations, disorganized speech, persisting for greater than or equal to 6 months, with at least one core positive symptom present for greater than or equal to 1 month. Aripiprazole, a dopamine D2 and serotonin 5-HT1A partial agonist and 5-HT2A antagonist, is a first-line antipsychotic with a starting dose of 10 to 15 mg/day orally, offering improved metabolic and extrapyramidal side effect profiles compared to typical antipsychotics. Key points. Note, aripiprazole is initiated at 10 to 15 mg/day orally for schizophrenia, with a maximum dose of 30 mg per day in adults. Dopamine D2 receptor occupancy by aripiprazole ranges from 75% to 85% at therapeutic doses, balancing partial agonism to stabilize dopaminergic tone. The lifetime prevalence of schizophrenia is 0.72%, 7.2 per 1,000 individuals, with an annual incidence of 1.5 per 10,000. Aripiprazole has a 5 to 10% risk of akathisia at doses greater than 15 mg per day, compared to 20 to 30% with haloperidol 5 to 10 mg/day. In acute psychosis, intramuscular aripiprazole is dosed at 9.75 mg or 15 mg, with onset of action within 90 minutes in 60% of patients. The number needed to treat NNT for aripiprazole versus placebo for greater than or equal to 20% reduction in positive and negative syndrome scale, PNSS, score at 6 weeks is 6, 95% CI, 5 to 8. Aripiprazole is associated with a 2.1% incidence of weight gain greater than or equal to 7% of baseline over 24 weeks, significantly lower than olanzapine, 31.8%, and risperidone, 12.4%. The FDA-approved aripiprazole Loroxo long-acting injectable (LAI) is administered at 441 mg, 662 mg, or 882 mg every 4 weeks, with steady state achieved by week 12. Aripiprazole has a half-life of 75 hours, range 43 to 113 hours, in extensive CYP2D6 metabolizers and 146 hours in poor metabolizers. The risk of QTC prolongation with aripiprazole is less than 0.1%, with mean QTC change of plus 2.6 milliseconds, 95% CI, minus 0.5 to plus 5.7, at 30 mg per day. In treatment-resistant schizophrenia, clozapine remains first line after failure of 2 antipsychotics, including aripiprazole, with a response rate of 30 to 60%. Aripiprazole is classified as pregnancy category C, with a 1.4-fold increased risk of major congenital malformations, 95% CI, 1.1 to 1.8, compared to non-exposed pregnancies. Overview and epidemiology. Schizophrenia is a chronic, severe neuropsychiatric disorder defined in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, DSM-5-TR, as a condition characterized by persistent disturbances in thought, perception, emotion, and behavior, with significant functional impairment. The ICD-10 code for schizophrenia is F20.9, schizophrenia, unspecified. The global lifetime prevalence of schizophrenia is 0.72%, 95% CI, 0.65 to 0.80, equating to approximately 51 million individuals affected worldwide as of 2023, WHO, 2023. The annual incidence is 1.5 per 10,000 person-years, with regional variation, higher rates in urban areas, 2.1 per 10,000, compared to rural settings, 1.0 per 10,000. Prevalence peaks in low and middle-income countries, mix, at 0.81% versus 0.67% in high-income countries, likely due to differences in diagnostic practices and access to care. The disorder typically manifests in late adolescence to early adulthood, with a median age of onset of 25 years in males, range 18 to 25, and 28 years in females, range 25 to 35. A bimodal onset is observed in women, with a second peak between ages 45 and 50. Schizophrenia is more prevalent in males, with a male-to-female ratio of 1.4 to 1. Racial disparities exist. African Americans have a 1.5-fold higher incidence, RR equals 1.5, 95% CI, 1.3 to 1.7, compared to non-Hispanic whites, potentially influenced by socioeconomic factors, diagnostic bias, and genetic susceptibility. Pathophysiology. Schizophrenia is rooted in complex neurodevelopmental and neurochemical abnormalities, with dopamine dysregulation as a central pathophysiological mechanism. The dopamine hypothesis posits that hyperactivity of mesolimbic dopamine pathways underlies positive symptoms, e.g., hallucinations, delusions, while hypoactivity in mesocortical projections contributes to negative, e.g., avolition, anhedonia, and cognitive symptoms, e.g., impaired executive function. Post-mortem and PET imaging studies confirm elevated striatal D2 receptor availability in unmedicated patients, with a 10 to 20% increase in D2 receptor density in the caudate and putamen. Aripiprazole functions as a dopamine D2 and D3 receptor partial agonist, with intrinsic activity of 60 to 70% compared to full agonists like dopamine. At presynaptic D2 autoreceptors, aripiprazole acts as an agonist, reducing dopamine synthesis and release. At postsynaptic D2 receptors in the mesolimbic pathway, it acts as a functional antagonist in states of dopamine excess, mitigating positive symptoms. Conversely, in dopamine-deficient states, e.g., mesocortical pathway, it acts as a functional agonist, improving negative and cognitive symptoms. This dopamine-stabilizing effect differentiates aripiprazole from typical antipsychotics, e.g., haloperidol, which are full D2 antagonists and may exacerbate negative symptoms. Clinical presentation. The clinical presentation of schizophrenia is heterogeneous, but core symptoms are categorized into positive, negative, and cognitive domains. Positive symptoms are present in 90% of patients at onset and include delusions, 85% prevalence, hallucinations, 75%, predominantly auditory, disorganized speech, 60%, and grossly disorganized or catatonic behavior, 30%. Delusions are most commonly persecutory, 65%, followed by referential, 40%, grandiose, 30%, and religious, 20%. Auditory hallucinations occur in 70% of cases, with voices commenting, 45%, or conversing, 30%, being most characteristic. Negative symptoms affect 60% of patients and include blunted affect, 55%, elogia, 45%, avolition, 70%, anhedonia, 65%, and asociality, 60%. These symptoms are often insidious and may precede psychosis by years during the prodromal phase. Cognitive deficits are present in 85% of patients, with impairments in working memory, affect size D equals 0.85, attention, D equals 0.75, processing speed, D equals 0.90, and executive function, D equals 0.80. Diagnosis. Diagnosis of schizophrenia follows DSM-5-TR criteria, requiring 1. Presence of greater than or equal to 2 of the following for a significant portion of time during a 1-month period, with at least 1 being delusions, hallucinations, or disorganized speech. 2. Social/occupational dysfunction for greater than or equal to 6 months, criterion B. 3. Continuous signs of disturbance for greater than or equal to 6 months, with greater than or equal to 1 month of active phase symptoms, criterion C. 4. Exclusion of schizoaffective and mood disorders, criterion D. 5. symptoms not attributable to substance use or medical condition, criterion E. Key points, delusions, criterion A1. Hallucinations, A2. Disorganized speech, A3, e.g., frequent derailment or incoherence. Grossly disorganized or catatonic behavior, A4. References. 1. Garcia Fernandez et al. Cariprazine and Cognition in Patients with Schizophrenia and Bipolar Disorder, a Systematic Review. Harvard Review of Psychiatry. 2024, 32, 6207-217. PMID, 395148868, https://pubmed.ncbi.nlm.nih.gov/395148868. doi 10.1097/HRP.00000000000000411. 2. Frogwas et al. Aripiprazole for the treatment of schizophrenia. Recommendations of a panel of Spanish experts on its use in clinical practice. International Journal of Psychiatry in Clinical Practice. 2023, 27, 182-91. PMID, 357927729, https://pubmed.ncbi.nlm.nih.gov/357927729. doi 10.1080/1365150.2022.20643008. 3. Reynolds G.P. High-dose antipsychotic polypharmacy and dopamine partial agonists, time to rethink guidelines? Journal of Psychopharmacology, Oxford, England. 2021, 35, 9-1030-1036. PMID, 342566637, https://pubmed.ncbi.nlm.nih.gov/342566637. doi 10.1177/02698811211026456. 4. Bojizin KB et al. Cerebral blood flow in striatum is increased by partial dopamine agonism in initially antipsychotic-naive patients with psychosis. Psychological Medicine. 2023, 53, 146691-6701. PMID, 367549993, https://pubmed.ncbi.nlm.nih.gov/367549993. doi 10.1017/S00332917230000144. 5. Grabowski et al. Partial D2 receptors agonists, pharmacological aspects, metabolism and use in the treatment of schizophrenia-related psychoses. Postopy Biochemii. 2025, 71, 4349-360. PMID, 415044732, https://pubmed.ncbi.nlm.nih.gov/415044732. DOI 10.18388/pb.2021_626. 6. Wichniak et al. The position statement of the Working Group of the Polish Psychiatric Association on the use of D2/D3 dopamine receptor partial agonists in the treatment of mental disorders. Psychiatria Polska. 2021, 55, 5941-966. PMID, 349977736, https://pubmed.ncbi.nlm.nih.gov/349977736. doi 10.1274/pp/138177. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.